Great. So hello, welcome to this edition of the About Time podcast. It's me, Chris Nichols, and as you know, in this series, I'm having conversations with people who I've met over the last 25 or so years, whose work I just find inspiring. And one of those is Professor Roger Kneebone. And Roger, I'm just delighted that you're here today.
Well, it's a great pleasure to be here, Chris, and I'm really looking forward to our conversation.
Yeah, and it's been a while since we've met. But we first met quite a long time ago at the Wellcome Trust, and I immediately was interested in what you did because our worlds cross over in so many ways. And on this podcast, I would love people just to get to meet you and to know about your work. And if we get the chance to cover a little bit of your story and just the work you do with expertise and how that relates to improvisation and all the magical stuff you do on simulation and bringing the public into work. I mean, there's so much we could cover, but it'd be great if you say something about just who you are, because you're about three different professors, aren't you?
Well, kind of, yeah. Yeah, so first of all, thank you very much for inviting me onto your podcast, and congratulations on your big birthday milestone. Yes, so as you say, we met, I don't know, 10 years ago or more, when I was in the middle of an engagement fellowship with the Wellcome Trust. So maybe shall I give you just a little bit of background about who I am and where I've come from. So at the moment, my formal title, if you like, is I'm a Professor of Surgical Education and Engagement Science at Imperial College London, which is one of the big London universities, and it specialises in science and technology, engineering and medicine. My own background is medical, so I trained as a medical student and then a junior doctor in this country 1970s, and then first decided that I wanted to be a surgeon. So after a few years doing junior hospital jobs in this country, I then went to Southern Africa to Johannesburg to work in a hospital for what I thought was going to be a year, but it ended up being more than 5 years, and I completed my surgical training there. And the hospital I was at, called Baragwanath Hospital, now Chris Hani Baragwanath, it was a huge hospital, one huge hospital for that enormous population of over 1 million people in Soweto, on the outskirts of Johannesburg. And a lot of the work I was doing there was dealing with violent injury. I was doing general surgery, so all kinds of surgery, but particularly trauma surgery, which is particularly interesting, I think, looking back on it, because it requires a very high level of improvisation and sort of reframing things in the moment, because I was dealing with people, a lot of them young men who'd been stabbed, sometimes shot, sometimes blown up, but mostly stabbed. And I did that for a couple of years. Then I moved to Cape Town and worked at the big hospital there for a couple of years. Finished my surgical training, became a consultant, and then spent a little while working in a war zone on the border of Angola and Namibia for several months, and that was an eye-opener too, and we can perhaps talk about that. But then after that, I decided I had a complete change of career direction, came back to this country, and wasn't really quite sure what to do next. So after looking at various possibilities, I decided to retrain as a general practitioner, a GP, family doctor. So I spent a year training as a GP in Lichfield, and then joined a 7-doctor practice in the southwest of England. And for more than 15 years after that, that's where I was. And I practiced as a GP. Then I became trained as a GP trainer. We can talk about what that means if you like later. Established our practice as a training practice, and became more and more interested in various sort of educational aspects to clinical work. And one of those involved developing, at the time, quite a revolutionary approach to teaching people about the surgical skills that they might need in general practice, using CD-ROMs. Remember those days, and working with a group of three-dimensional graphics experts, and that came to the attention of the then Professor of Surgery at Imperial College at St Mary's Hospital, when I went to a conference. Ara Darzi, now Lord Darzi, who then, rather to my surprise, invited me to present my work to him, and then suggested I come and join his department. And after doing that for a year or two part-time, I then decided to resign from my practice and come to Imperial full-time, and I've been here ever since, not practicing clinically, but first of all, I developed and established a master's program, a master's in education, in surgical education. So lots of masters in medical education, but not in, this was the first one anywhere, in surgical education. So that was inviting surgeons of all levels of experience, from right at the beginning of their career to being very experienced consultants, to engage with the worlds of education and the social sciences and the humanities in ways that they often hadn't thought of, as even though they were often very experienced teachers and of course had all spent a lot of time learning, but they hadn't really thought about surgical education in that broader sense of its connections with the wider worlds of the humanities and the arts and so on. So I've been doing that for the last 15 years or so. That's now just coming to a close. But alongside that, I developed an interest in simulation, as I don't know, people will be familiar with simulation probably from aircraft cockpit simulators and things like that. And over the years and now decades, have developed a number of approaches to using simulation in one way or another to explore aspects of skilled professional work. And one of those led then to me establishing a collaboration and jointly leading a Centre for Performance Science between Imperial and the Royal College of Music, which is one of our very close next door neighbours, in fact, just behind the Albert Hall, for people who know that part of London at South Kensington, where the big museums are, the V&A, the Science Museum, the Natural History Museum, and the Royal College of Music, where my colleague Aaron Williamson had been leading a Centre for Performance Science that focused largely on music, and we expanded that to look at what performing might mean in areas of medicine and science and engineering. And that's been fascinating because it's prompted a whole range of different kind of explorations, I suppose you would say. And then the other thing that happened about that time was that I was extremely fortunate in being awarded an engagement fellowship, the one I mentioned at the beginning, with the Wellcome Trust, which many people will know is an enormous and very influential medically focused charity, which at the time had a very strong interest in public engagement and the intersection between medicine and the arts, performing arts, the visual arts, all kinds of things. And so I was selected to be one of two people in the second year of this new program, which gave people 2 years or a bit more sometimes, really to focus on exploring ideas around public engagement and what that might mean. And to me, that was a sort of extraordinary time of freedom, because it allowed me to step aside from my work at the university and work for much of my time just developing ideas and testing out ideas of how we might think about creating connections between this often closed off, inaccessible insider world of medicine and surgery and things, and the outside world and members of the public, grown-ups and children, all kinds of things. So we did a lot of stuff using simulation to show operations and all kinds of things at music festivals and arts festivals and public engagement events, all sorts of things. And that's when we met, because one of the ideas of that fellowship was to give people the support they needed to develop their careers in different ways, and we had all sorts of very useful sort of coaching sessions, didn't we, really, when we were
I,
talking about some of these ideas.
I think it was play, wasn't it?
Yes, yes, it was. Yes,
Very purposeful play. It was very good.
yes. And that's really what led to what I'm doing now, which is at Imperial. And since then, I've become more and more interested in several areas. One is what happens if you look at an area of, well, expert work, what expert work means. I wrote a book about that a couple of years ago, and thinking about what you might see if you look at any area of expert work in terms of in terms of craftsmanship, how people do whatever they do with their hands and their bodies, and performance, and how people are performing and what that means. And so I've been thinking about that a lot. And then another project that I'm leading at the moment is called Sharp, and it's about trying to reduce the impact of knife violence on young people by using simulation to show so far the story of somebody who gets stabbed and goes through the health system, roadside assistance for a seriously injured person found in the gutter, life-saving surgery, but a life-changing consequence. Looking at that through physical simulation, showing the medical pathway, but also using various arts-based approaches to look at the emotional impact of all of that. And now, having done that with getting on for 600 young people over the last 2 or 3 years, wanting to look at the other side of the story, which is the story of whoever's holding the knife, or always suspected of doing that. And that's not the health service, that's the criminal justice system. So that's police, magistrates, solicitors, barristers, judges, prisoners, all that. And so these two, again, I think, are looking at different kinds of expert performing that have real world consequences for different kinds of people. And that's probably a good point just to shut up now and
it's already like we could run a master's degree just pursuing the different avenues you've set out. So I didn't know about Sharp, so I definitely want to know about that. But let's give the book a plug, because I do want people to know about it, because it's a book I read when it first came out, and I've just recently listened to the audiobook, which you narrate yourself, and I think it's a really lovely thing. And the thing it gave to me was, I think expertise gets a bad rap at the moment. We a few years ago, probably 10 years ago now, we had a government actually telling us the world was fed up of experts.
Yes.
But what delighted me about the book was, first of all, the rejoicing in expertise, but you also then take quite a big view of it. Lots of people, and I think classically expertise gets contained as, oh, well, it's doing the right thing in the right way. And actually, you show that experts can learn in all kinds of different ways, and that improvisation is an essential part, kind of fingertip learning is an essential part of it. So I just wondered if you could say something about, you said like in surgery or trauma surgery, it's always got improvisation in it. I mean, most of us know nothing about the life of the trauma surgeon. So what do you mean?
What do I mean about improvisation? Well, trauma surgery is a good example, I think, because in order to do trauma surgery at all, you have to do the things first that any surgeon would need to do in order to be allowed to operate. And let's say we're talking about what goes on in the operating theatre. There are many other bits of surgery, of course, trying to make sense of what a problem is, trying to, looking after people afterwards. But let's just focus on what goes on in the operating theatre. And so in order to do that at all, you need to have learnt a whole lot of stuff about anatomy and physiology and past exams and things like that. Of course you do. And so there you learn what people look like on the inside in enormous detail, and all the names of all those structures of organs and arteries and nerves and things like that. And of course,
I remember in the book, Roger, you refer to your professor referred to all those little buggers in the neck.
Yes, that's right. Yeah.
Was it the
Yes.
structure of the neck being particularly
The
difficult?
structure of the neck is particularly difficult because it has got many, many, many little tiny things, little muscles going this way and that way, and nerves, and they're most of them are pretty important, and you can do a lot of damage in a very short space of time in a very confined area. But other parts of the body are like that too. But this is very interesting because this studying that you do is a question of memorizing things. And I spent a year teaching anatomy to medical students when I was studying for surgical exams and things. So I saw a lot of examples of the insides of people, and I tried to match that up with what I had learnt from textbooks and things. And I needed to have it in the front of my mind so that I could answer questions about it in stiff exams. Okay, and that was the starting point. But then, of course, two unexpected things happened well, first of all, an unexpected thing that always happens when you operate on somebody is that everybody is slightly different. And although you have a general idea of where things should be, and that's usually okay, it doesn't tell you exactly what you will find in that particular patient. So there's a difference between anatomy and morphology. And so the arrangement that you expect to find gives you your compass bearings when you start to open somebody up, and you need to get to the bit that you need to get to. And very often in elective surgery, as it's called, you know in advance which bit that you need to get to. You're taking out somebody's gallbladder, you're taking out half their stomach. So you know what you're aiming for. And of course, it can turn out to be different when you get there, but largely you've got a sense in your mind before you start of the kind of thing that you're going to encounter. Now, you have to be aware that there is an enormous amount of individual variation between all of us. And sometimes that doesn't particularly matter if this little tiny vein is here or half an inch to the left. It doesn't matter if that little tiny vein isn't doing much and you can safely tie it off or something. But some parts of the body, it really, really, really does matter. For example, at the base of the liver where the gallbladder goes in, the way the arteries and structures coil around one another it's not always the same. And you can easily get caught out if you don't look very carefully, because you can cut the wrong thing and cause damage. So you have to sort of train yourself to be particularly alert in areas where it really matters. And that's with any kind of surgery. And I'm talking now about open surgery, because when I was doing this in the 1980s, it was before keyhole surgery had come in. And so all operations, somebody was under general anesthetic, you made an incision in their abdominal wall or their chest or whatever, opened them up and looked directly inside. But trauma surgery is particularly unpredictable, because let's say somebody's been stabbed with a knife. Usually you see a patient with a stab wound, but no longer the knife, because they've been stabbed, knife's gone. So you know where the stab wound went in, but you have no idea whether it went in downwards or upwards or backwards, or and so you really cannot tell until you open somebody up whether you're going to find a trivial injury on the very surface or whether you're going to find some devastating thing that goes into many, many really serious organs. So when you start, you have to try and make sense of what's there. Sometimes, for example, things can change very quickly. You find that everything seems to be quite stable, but actually you just move a little tiny blood clot with a swab. It turns out to be on a big artery, and whoomph, the whole thing fills up with blood. There are unexpectednesses in terms of the physical damage, but also in terms of the tempo and the speed with which those things become disclosed. And also, you can find that these knife wounds, because they're not deliberately aimed, except at causing damage, they can go into parts of the body that you rather go to, because with orthodox training, you tend to build up your skills. You start off with an easy version of whatever that operation is, and then you might go on to more complex ones. But with this kind of thing, you just don't know. And so you may find that something you thought was a fairly straightforward thing into the top part of the abdominal cavity, for example, goes in through the diaphragm into those large blood vessels that come out of the heart, and think you can find yourself in really frightening territories. And so there are all kinds of unpredictablenesses that require you to improvise, and that by improvising, when I started writing about this in the book, I thought people often think about improvising as a sort of bit of laziness, couldn't be bothered to learn how to do it properly, improvised something, made it up on the spur of the moment. But absolutely not. I think improvisation is one of the very highest forms of expert skill, because it involves sort of making a rapid judgment about what is going on, how what is going on is departing from what you expected and hoped, what you could do about it, which of those many things you should do about it, and then doing it, all in the twinkling of an eye.
Yes. So,
And
and
I mean,
then
it's not only in surgery that happens, but that's the one I had experience of particularly.
yeah.
Uh, and I think the more I think about it, the more I think that improvisation, in that sense of recognizing and responding to deviations from the expected and doing something appropriate and sensible, lies at the heart of being expert.
Yeah. And when we first met, the reason I went, oh my God, I want to spend time with this guy, was because you were introducing, like you were bringing embroiderers and
Yeah.
puppeteers and close-up magicians to work in surgical education, sometimes because of the improvisational edge, sometimes because of other aspects of the work. I mean, how did you even start to do that?
I'm trying to think back. I mean, I've always been interested in. I've always been interested, I suppose, in people who do the same kind of thing in different ways. So, for example, when I became a GP trainer, I was thinking about how an experienced GP can help an inexperienced GP recognize what is salient in a consultation, say. And I was thinking about my own experience as having music lessons when, so as a GP, I'd gone through this stage of being a GP trainee and being completely at sea with all these differences between hospital medicine that I was used to and general practice, which I wasn't, feeling completely adrift and not knowing how to make sense of all this complexity and all the rest of it. And then having the guidance of an expert trainer myself, and then later on, several years later, going through the process of learning to become a trainer and supporting other inexperienced GPs. And I was thinking about my own experience in learning to play, in my case, the harpsicord, which is an instrument that looks a bit like a piano but doesn't behave in the same way at all. But I've been having lessons with a very expert teacher. And so I started thinking about how did Sophie Yates, my teacher, how did she, as a very expert person, put her finger on what was concerning me or what I was struggling with? Because quite clearly, what I was struggling with, she wasn't struggling with, because she could already do that. She's very, very experienced, eminent recitalist and broadcaster and recording artist, all that kind of thing. But what she was extraordinarily good at is listening very attentively to what I was playing and hearing things that I had not noticed because I was too close. I was focusing on one thing. I was focusing on, fingering or articulation or whatever, or just trying to play the notes really. And she was thinking much more widely. She was thinking, okay, she might think about how I was sitting at the instrument, or the fact that I was thinking more about the notes than I was about the rest that surrounded them with silence, or she might even think about whether actually maybe we ought to try another kind of piece of music altogether, because this one just wasn't working, or it was time to move on. So the things that she was concerned about were not the things that I was concerned about, and that made me think about how might this play out in the medical world and these other worlds, really, of when very experienced people share or what is it that they do share with less experienced people, when those less experienced people are aiming to improve in some sort of area. And so I started thinking more generally, can we think of other examples of that kind of thing? And so working with the Royal College of Music, that was very helpful. Lots of people there who who have different kinds of expertise, but then began to think, well, the other thing that happened was that I, again, quite by chance, discovered the Art Workers Guild.
Yes.
And the Art Workers Guild is an extraordinary organisation in London, based in London, but with members all over the country. And these are people who are extremely skilled at what they do, and they are a whole range of different kinds of craftsmen, particularly people who work with their hands, men and women, young, old, all sorts of things, wood engravers, ceramicists, embroiderers, all kinds of people. Fascinating group. The guild was set up in the 1880s, sort of arts and crafts movement time, and one of its first masters, as they're called, was William Morris. So it goes back to that sort of valuing the beauty and excellence of good work in that sense. And so I started to bring some of the ideas I was developing around surgery as an area of craftsmanship to the Artworks Guild. And I remember organising an event called Thread Management.
Yes.
And that goes back to what you were saying about the embroidery. One of my colleagues there, called Fleur Oakes, is a very experienced.
She was the artist who did the textile body. Is that?
Yeah, she did the textile body. She first recognised. We had various people who used threads coming together. You know, Fleur, an embroiderer, had a vascular surgeon sitting next to her. Then there was an angler, you know, using threads to throw a hook very accurately a long way, but also to tie those tiny little flies, and some puppeteers, all sorts of people who used threads. That was the thing that brought them together. And Fleur was sitting next to the vascular surgeon, and that led to her spending 3 years as the embroiderer in residence at Colin. He's the consultant vascular surgeon at his vascular surgery unit at St Mary's Hospital, part of Imperial College. And so she watched surgery for years, but she didn't have all that knowledge that I told you about, learning about anatomy and things. And she hadn't had anything to do with medicine at all. But what she noticed was techniques and how people were using threads. She noticed colours. She's trained as an artist. She noticed colours and the sort of play of light on a pool of blood on a blue drape, all that kind of thing. And so she came up with various representations of the inside of the body using textiles, using layers of textiles, using very, very beautiful creations that she makes, very detailed, very small scale, that allow people to understand some of those things about how you explore a part of something that is complex, beautiful, and clearly vulnerable without damaging it, but being sufficiently decisive to open up bits that need to be opened. I don't know if that makes sense. I mean, it's difficult without seeing it, but we could put up a couple of links if people are interested.
I think we will do that. We'll make sure we put some links up. Although I must say, round about the time you introduced me to the whole idea of thread management and the work you were doing in that, I had some surgery removing a little lump somewhere in the back of my mouth. And after the surgeon had taken it out, I'm just going to stitch that up. He said, you might want to close your eyes. I said, no, I'm not going to close my eyes. I have to watch because I'm interested in, of course, I had loads of tools in my mouth. I'm interested in thread management. So I was watching all these loops of thread go around.
Yes, it's very interesting, isn't it?
Yeah.
Exactly. And so once you start to think about the focal point being thread rather than teeth or something, you know, you're looking at something that's still there. It's been there all the time, but the lenses that you use to look at it change entirely. They bring into focus some parts of the picture and they blur out others. And I think what I found was that, having had a medical training, the things that were in sharp focus were the details of what was the name of this artery and what was the disease that was causing, and what was blurred out was the whole of the rest of the picture. But when you bring people in who have a different kind of expert experience, either as performers or as craftsmen or both, then you see things through their changed focusing knob. And so you you get an insight into what strikes them as salient, because for them, almost all of them, they're not interested in whether this is the second or the third branch of that nerve. They're interested in what people are doing together and what these structures look like and what are the techniques. And so that's when the penny dropped for me, that might be something worth looking at systematically and trying to get a bit more of a sense of what different people see. And at about that time, I started a podcast series when I was at the Wellcome. So this is 10 years ago or so, which is about when we met. And you kindly took part in one of the early ones. And that too was interesting, because that was different from being in an operating theatre or being in a sculptor's studio or a wood engraver's workshop or something. That was talking about things. And it started off, I think it was before podcasts were a thing, and it was very experimental. I thought I'd perhaps do 2 or maybe 3. I was able to use the studio at the Wellcome, and now I've done 250 of them. And it's been going on for 10 years. But it started off as a sort of interview. I had a list of questions. I said, very nice to see you. So, where were you born? What did you do? But very quickly, I started to think that wasn't what I wanted. And I've framed it as a conversation where neither of us knew where it would go. And each of us, there's another instance of improvising, really. Each of us would respond to what the other one had just said, and the thing would take shape. And who knows where it would go. And so my job was to try and to have a conversation, enable a conversation, which I found interesting at the time, and I hope my interlocutor would as well.
Yes.
I had an additional responsibility, which was to try and shape it in such a way that somebody hearing it afterwards who didn't know either of us would also find it interesting. So partly, keeping to time-ish, it needed to be about an hour. Couldn't really stop after 3 minutes, but on the other hand, it couldn't be 4 hours. So broadly speaking, had to sort of get it to take off and then get up to cruising altitude and stay there for however long, and then come down to a graceful landing at about the right time, and also to be comprehensible to other people, because people who are very enthusiastic and expert about something often use abbreviations or shorthand or whatever, which somebody listening might not understand. So there was a bit of the, when you say it was a W5, what do you mean, kind of thing. And so that was also a really interesting, still is a learning process of exploring people away from where they normally do whatever it is that they do, and talking about it, but also developing a conversation about how our very different experiences might come together to enable a conversation that would be of interest to other people. And I mean, we did that, didn't we, a while ago?
We did. Roger, I mean, I'm conscious that time is flying by, and there's 2 more things I definitely want to ask you about. One is simulation, because we share an interest in simulation, and you have done amazing things like taking inflatable igloos which blow up and turn into an operating theatre to pop festivals and all kinds of things. So I want to ask you about that, and I want to ask about Sharp, which I knew nothing about. So could you just say something about your interest in simulation? And
well, I've always been quite interested in simulation as a way of allowing people to practice things that they're not yet sufficiently good at. I mean, medical things is where it started for me, in order to get good enough in order to do things on real people without causing damage. And of course, there's a long history going back centuries of simulation, of people practicing things on models of one sort and another. But when I came into the picture, I mean, I hadn't really had much use of simulation at all as a medical student, and as a junior doctor, it wasn't really there. But by the time I came back from having done all this surgical stuff, there were simulation centres were growing up, and there's a lot of investment 10 or 15 years ago in very expensive highly sophisticated centres where you could go and see a recreation of an operating theatre or an intensive care unit, rather like the Boeing 747 cockpit simulators, that sort of thing. And they were very expensive to put in, very expensive to run, and crucially, their access restrictions were pretty much like those of the hospital settings they set out to represent. So unless you were a surgeon or a scrub nurse or an anaesthetist or something in training, you couldn't even get into them, even if you could find one. So I thought, well, maybe we could look at this differently. And so I started working with a couple of recently qualified design engineers from the Royal College of Art, Matt Harrison and Cian Plum, and I gave them a brief. I said, okay, can you come up with a portable operating theatre that costs less than whatever it was, £2,000. I mean, these places cost millions. Those cost less than whatever it was, and you could put in the back of a small car. And so they did some trying out, and they came up with this idea of an inflatable enclosure into which that was blue and white. It looked sort of vaguely clinical, in which you put one or two things that were highly realistic anatomical model of the inside of somebody's tummy, say, and a couple of lights and things, but the rest of it was pretty rudimentary. And the idea was that if you were focusing very much on what you were looking at, you don't really notice what's around the outside. And this proved to be very effective. And it worked a lot. It worked well with insiders. But then this was welcome time. And so I thought, well, the whole idea of these simulated environments is that they keep outsiders out. But what happens if we turn that on its head and we use this as a way of inviting outsiders in? So we opened this thing up and invited members of the public and children and all sorts of people to come in and see surgeons doing things, surgical teams doing things, and then share their ideas with us about what it meant to them. And so that is where we developed this idea of reciprocal illumination, of a sort of sharing and enriching of perspectives by having conversations with people you wouldn't normally have conversations with, because they weren't operating on you or your son that day. They were showing what that sort of operation might be and then talking about it. And so that led to this whole idea really of engagement in a broader sense. And then I started systematically inviting craftsmen to come in and watch the craft-related things, performing artists, musicians and magicians and comedians and dancers and people to come in and watch how people were working together with their bodies, how they were doing things with other people in groups. And that led to a really interesting set of collaborations, and indirectly to Sharp, because one of the things we did at one of the public engagement venues, the Big Bang Fair, for children and young people, I think 50,000 of them over 3 days or something, at the Birmingham National Exhibition Centre on one occasion, we showed a sequence of events when somebody, an actor, had been stabbed. We called it life on a knife edge. And we showed this sequence of events. Somebody gets stabbed, some real police came and real ambulance paramedics. And then the next part of the story was to see a surgical team in this inflatable operating theatre doing a life-saving operation. And then the third stage was to see the patient waking up and finding that they had a colostomy, in this case, a poo bag to divert them, because they'd had an injury to the intestine. And so that was looking at the sort of long-term effects of something that goes on far beyond the moment when somebody leaves hospital. And we did this with, groups of 120 people watching us each time or something. And that really led to me thinking, well, okay, knife violence on young people is a huge and worsening problem, as everybody knows. And it's only getting worse. Whether we could use that approach to not just present this to whoever chose to turn up, but focusing on people who were at risk. And so we got funding from the Youth Endowment Fund, branch of the arm's length branch of the Home Office, to do a project doing that, this sort of sequential simulation with 11 to 14-year-olds in parts of London where knife violence was a particular issue, and people from areas of deprivation and educational issues, all kinds of things. We got quite a bit of funding for that, but the week after it was confirmed was the first national lockdown for COVID. So we couldn't do any of the stuff that we were intending to do at all. So we had to reframe it. And the first thing we did was to develop a virtual reality account of what we had been doing with physical simulation. And the other one was to work with artists to see if they could help us find ways to engage with young people, vulnerable young people, around the emotional aspects of what they'd seen made them feel, because over 70% of them had actually experienced knife violence themselves in one way or another, in their family, their schools, their communities, occasionally even themselves. And we didn't want to traumatize them needlessly or whatever. And so we did two things. One was a visual artist, Merlin, just got the young people, after they'd seen this VR thing, virtual reality thing, to make marks with black ink on white paper, and then cut those black blotches up and stick them onto pieces of orange card. And this meant that you didn't have to have any artistic skill or anything. It was something anyone could do. But they came up with these extraordinarily moving images of the impact of what they'd seen on particularly the families and friends of people who'd been injured. And then the other thing was Fleur Oakes, whom I mentioned earlier, created an extraordinary thing called Somebody. It took her 18 months, which is a huge book, an embroidered book with pages. And when you open them in one direction, you go through the layers of the body represented and the organs of the body represented by beautiful embroidery. But when you turn the book over and turn the same pages in the other side, it shows the sort of lived experience of somebody who's got caught up in being arrested and being sort of trapped in an environment they can't get out of for a while, and then looking more optimistically at alternative possibilities for deciding not to carry a weapon, all that kind of thing, through embroidery. So it's highly unconventional, and that's performed when we do our sessions by a puppeteer who is Rachel Waugh, who's very skilled at making objects tell a story. And so we brought together these different parts of the picture. And so far we've focused on what happens when somebody gets stabbed. We don't say who or why or anything like that. Looking at a system that people, I think, generally trust. But now, of course, if you're young and there's a knife anywhere in the picture, it literally is a toss of a coin which end of it you end up on, whether you get stabbed or whether you're in a group where somebody gets injured. And if you're on that side of it, it's a very different story. You're immediately in a system that most people don't trust, because it's arrest, it's custody, and then it's youth courts and magistrates courts and crown courts possibly, and all the rest of it. And so we now want to try and look at that side of the picture as well, not to freak people out, but to try and give them information that will help them make safer choices in the heat of the moment, when things can easily get out of control very quickly, especially when you're very young. And your powers of consequential thinking haven't really settled down yet. And so that's one of the sort of practical things we're doing at the moment. But it brings together all these principles that we've been talking about, of working with different expert people who have very different perspectives on, in this case, a challenge that really needs to be addressed, namely making young people safer at a time when knife violence is increasing.
Oh, that's brilliant work. I didn't know anything about that, Roger, and it's just fantastic to know about it. If people want to find out more, is there stuff online that we can put a link to?
Yes, there's plenty of stuff online. I mean, I've got a website with stuff about this and many other projects. We've got a Sharp website too. We're obviously very keen to collaborate with people who want to collaborate with us. We're looking for support and funding to develop this whole justice system side of things, so that we can put the two alongside one another as a kind of preventive measure, really, because it's a bit like, I think it's a bit, knowing what to do if there's a knife somewhere is a bit like needing to have your seatbelt on when you're in a car. You just don't know when you're going to need it. And you need to have it on there before you get in the car. So you really need to know how to keep yourself safe in these days of increasing peril with knives, I think. But all this other stuff that we've been talking about, the intersection between medicine and science and the performing arts and the areas of craftsmanship, I think is very interesting. And there's lots of stuff on my website if you like, and
Yeah.
lots of stuff we published.
Roger, we will make sure that we put a link to that, and we will put a link to the really excellent book, Expert. I mean, I love it. This has been brilliant. We've already done 50 minutes, so we're going to have to stop. We could, I mean, we could have fun for ages. Roger, I'm just so grateful to you. Thank you for.
Well, it's been such a pleasure to catch up again, Chris, and we
Yeah.
haven't really had a chance to talk at all about what's happening around for you around this pivotal 65th birthday point. And
No.
I just if we've got a couple of minutes at the end, I wanted to ask you what are you thinking about? You said you're doing this as to mark that moment.
Mhm. Yeah. So, what am I doing? Well, since I turned 60, I've been doing more art, as in more art, taking my art more seriously, or taking my playfully seriously. So I did a year at St Ives School of Painting, the Porth-Meal program. I've discovered I'm more of a printmaker than an oil painter or something like that. I do like printmaking. Um, I'm going to continue exploring the connections between things, Roger. I love it when one field feeds another, when people look through a different window and new possibilities emerge. So I shall continue doing that as long as I can walk around and keep breathing. So that's what I'm planning to do.
So we must have another conversation when it's your 75th birthday, and another one when you're 85.
But let's not leave it that long. Roger, I'm going to stop the recording in a moment, but I just want to say formally for the film, thank you so much. And I want to say to everybody who's been looking, thank you for taking a look at this. This has been Roger Kneebone. The links are in the text below, and we'll be doing more of these over the coming weeks. Thank you all very much.